We are going live in 5, 4, 3, 2, 1.
Good evening and welcome to our weekly Cerebrovascular and Skull-Based Symposium of the University of Miami. This is our 19th session of the Thursday series. I'm Jacques Morcos, professor and co-chair of the department, director of vascular and skull-based surgery. Co-directors of this course are Carolina Benjamin, assistant professor in our department, director of the Keynes Dissection Lab, specializing in brain tumor and skull-based surgery. Mike Ivan, assistant professor, director of research at the Brain Tumor Initiative, specializing in brain tumor, skull-based, and epilepsy surgery, as well as my two endovascular and open vascular partners, Bobby Stark and Eric Peterson. This is wonderful Miami. Those of you who visited will recognize this iconic picture at the top left. At the bottom are our two main hospitals, University of Miami Hospital, Jackson Memorial Hospital. Naturally, we're a high volume tertiary referral center. Housekeeping instructions for tonight, audience members. Please use the Q&A box at the bottom to send your questions throughout the lectures, and we will address them during the discussion time at the end. We don't offer CMEs. Please share the links for our weekly seminars, both the Wednesday and the Thursday ones, in your social media if you think they are worth listening to. I will remind our two speakers 2 minutes before the end of their 25 minutes of the time to keep us on schedule. Please send me any suggestions you have for future topics. I am continuing to build future topics into December in cerebrovascular and skull-based, or any speakers you would like us to consider. This is my email. I'm on Twitter. For next Thursday, we will have a vascular topic. We'll have Elad Levy from Buffalo and Rafael Tamargo from Johns Hopkins talk about endovascular and microsurgical aspects of aneurysm treatment. And at the bottom right is the link to register, but you already know it since you registered on this one today. The Wednesday series that my partner Mike Ivan has been holding even longer than my series here is the Miami Global Brain Tumor Symposium has been extremely successful as well. I encourage you to join next Wednesday, same time, 5 p.m. For George Samanduras, who will talk about pineal and third ventricular tumors. Many thanks to our whole team that makes this happen. Ingrid, Roberto, Cristina, particularly Ignacio, who runs this symposium every week. These are different ways for you to connect with us, to watch previously recorded sessions. They are all on our website through the link you see at the top. You can connect with us, email, Instagram, or Twitter accounts. It's my pleasure to welcome our 5 panelists today. First, Marvin Berg-Snyder. Marvin is a dear friend for many years. He's professor and director at the UCLA Pituitary and Skull Base Tumor Program in LA and has a vast experience, particularly in pituitary surgery. And he will be one of our panelists today. Thank you, Marvin, for joining. Apio Antunes, all the way from Brazil, as if you get extra point for being in Zoom from another country, Apio, but welcome. Apio, also a friend for decades now, associate professor, chairman of neurosurgery at the University Hospital Porto Alegre Medical School in Porto Alegre, a vast experience in pituitary surgery. Roy Cassiano, now who I've known, I guess, exactly 25 years since I've been here. 25 years, he's been here longer at the University of Miami, the head of rhinology, sinus, and also skull base, my partner in crime in most of these surgeries, along with the other rhinologists, of course, with whom us neurosurgeons work with here at the University of Miami. And Roy will cover some topics in skull base repair today. And very importantly, our 2 colleagues from endocrinology who really run the medical aspect or endocrinologic aspect of our pituitary program, Atil Karji, Associate Professor of Clinical Medicine in Endocrinology, originally did his medical schooling in Izmir in Turkey and has been here several years, and Alejandro Ayala, who I hope will be able to join us, Associate Professor also of Endocrinology, has been here many years. These 2 gentlemen are absolutely essential, of course, to the pituitary program, and I'm sure you will all want to hear some endocrinological aspects to the care of pituitary patients. So now on to the 2 speakers of the evening. Let me start with Nelson Oyeshiku, who is professor of neurosurgery and medicine of endocrinology. He is the Al Lerner Chair and Vice Chair of the department. He is a co-director of the Pituitary Center at Emory University in Atlanta. Nelson has done his medical schooling at the University of Ibadan in Nigeria. That's where he's from originally. Then did an MS in occupational medicine in London, then PhD at Emory in neuroscience, stayed there for his residency in neurosurgery at Emory, has been there ever since. I cannot begin to list all the list of accomplishments that Nelson has, but these are just a few. He is, of course, currently the World Federation of Neurosurgical Society president-elect. His term will start in August of 2021. He's past president of the Congress of Neurologic Surgeons, of the Society of Neurologic Surgeons, past vice president of the American Academy of Neurosurgery, past chair of ABNS, RRC, ACS Board of Governors, past president of International Society of Pituitary Surgery, and of course, probably most of you know him as the most able and most creative and amazing editor-in-chief of the journal Neurosurgery. And between all of these things, he still has time to operate on, I don't know how many hundreds of pituitary tumors a year. Perhaps he will tell us. And Nelson is beloved. You can see there, Gentle Giant Award at Emory that he received several years ago. You can see him with his family there in the middle. and you can see him celebrating his Nigerian African heritage at the bottom after he was elected WFNS president-elect. So Nelson, great and warm welcome. On to Eduardo Vellottini, a friend of many years. Eduardo is neurosurgeon DFV at Neuro in Sao Paulo, Brazil. Eduardo did his MD and neurosurgical residency in Sao Paulo University, did 2 fellowships, one of which was of course quite influential for 2 years in the mid-80s with Majid Sami in Hanover, then did another one with at University of Pittsburgh in Naligam Shekhar in 1990. He went on to specialize in skull base and pituitary surgery. You can see all his accomplishment as coordinator of skull base group, Hospital de Clínicas in Sao Paulo for about from 86 to 2000. Then at Hospital Servidor Público in Sao Paulo till 2016. Then he became coordinator of Sao Paulo skull base group, coordinator of pituitary diseases group at the Hospital Syrio-Lebanese in Sao Paulo, and currently also at Hospital Alemão Oswaldo Cruz. And Eduardo specializes particularly in complex anterior skull base and pituitary surgery. So we have 2 superb speakers for you today to discuss the topic. And I don't know if Nelson will have to leave us for surgery later. Iggy, my mouse doesn't work. Can you stop me sharing so Nelson can get his talk, please?
Yes, doctor.
I can, for some reason, yes, you got me? Thank you.
Yes, doctor.
Nelson, I invite you to load your slides, unmute your microphone, and start your presentation. Thank you so much.
Thank you so much, Jack, and all fellow panelists and participants. It's a tremendous honor to be a part of the symposium. As Jack alluded to, I've been tasked with leading off this afternoon, talking about functioning pituitary tumors, and we'll discuss techniques, results, and lessons that we would impart to someone else and that we've picked up along the line. I work at Emory University in Atlanta. We have a pituitary center, which is a multidisciplinary group of physicians looking after these patients. I do not have any disclosures to speak of. So let's lead right off into the topic at hand. So functional tumors of the pituitary gland, of course, arise from the specialized cells of the anterior pituitary. The big 3, as I like to call them, Cushing's disease, which is from the corticotroph lineage, the acromegaly or the gigantism from the somatotroph lineage, and then the Prolactinomas from the lactotroph lineage. There are 2 other groups of functional tumors that I think are bear mentioning, but they're rare enough that I will just touch on them in this discussion. And those are the gonadotropinomas and the tyrotropinomas. And it's also true that oftentimes these cells will combine to have co-secreting tumors, such as, for example, co-secretion of growth hormone and prolactinomas, which is very, very well seen, or gonadotropinomas and tyrotropinomas, or Cushing's and prolactinomas, and so on. As a group, I think it's fair to say that the functioning tumors are rare diseases as a group in general. So for those who dedicate a substantial amount of their time to pituitary and skull base, will see many of these tumors. So I will touch upon the syndromes, the treatment, presentation, and so on. I'll discuss the techniques as a group towards the end, and I'll mention lessons that we've learned along the way. So this is, there are 3 figures in this slide that I think are quite important. So the pituitary gland has a topography to it. And by that, I mean that there are cells that occur in different locations. And in general, they tend to respect those borders. It's not absolutely concrete, but it is significant enough that it bears mention. For example, growth hormone tumors and prolactinomas are most likely found in the lateral wings of the gland and generally originate there. They may not stay there, but originate there. The anterior pituitary has what's called a mucoid wedge where the corticotrophs generally tend to reside. And the other thing about the topography that I think is important in terms of exploration of the gland looking for tumors is that there's something called the pars tuberalis, which means that there's part of the anterior pituitary that ascends along the infundibulum. And it is in fact the case that some tumors will arise within the pars tuberalis or transinfundibular tumors. For example, Cushing's, I've operated on at least 3 cases in this location, and also growth hormone tumors. And then finally, although the posterior lobe is usually not the area of origin, it is in fact the case that tumors of the anterior pituitary can start out in the posterior lobe. And I think this is extraordinarily important when looking for microadenomas of the anterior pituitary, to keep these things in mind. The blood supply, of course, as you know, is the majority of it is coming through the superior hypophyseal and the portal vessels. The inferior hypophyseal mainly goes into the posterior lobe, and then there's a lot of artery to vein and vein to vein blood supply. So let's start off with Cushing's disease. So the fair market value for the incidence of Cushing's is about 3 per million to 5 per million. So if you do the math from, for example, where I live in Atlanta, we have a 6 million catchment area in the city and 10 million in the state, which means you see about 30 to 50 cases a year. The prevalence is high, of course, and it's fair to say that Cushing's is a morbid disorder, and it is not fun living with Cushing's because of the diverse and severe consequences on metabolism, general livelihood, and some things that people tend to ignore with Cushing's are the psychopathology and the cognitive impairment. If you do an MRI on a patient with Cushing's, you'll see a lot of frontal lobe atrophy, almost like the patient had CTE, for example. Anxiety, depression are very important parts of Cushing's. And of course, we all know the other stuff that's more common: diabetes, hypertension, atherosclerosis, immune suppression, and so forth. And if it's left untreated, it will decrease life expectancy for sure. So how's the diagnosis made? I know we have endocrinologists on the panel. I'll be very quick through this. The most important thing, first of all, in the setting of suspicion on the basis of clinical parameters, is to first establish that there is hypercortisolism. In other words, the patient's making too much cortisol. That can be answered, that question, by 24-hour UFC, for example, as a screening tool. And then lack of diurnal variation with the midnight salivary cortisol, which would be obtained after the patient normally would be going to bed. And that should be high in Cushing's, and in those that do not have Cushing's, it won't be. Then you have to establish ACTH dependency, because Cushing's obviously is an ACTH dependent corticotroph adenoma. It's just that the set point is higher, and you can answer that question by ACTH levels and the CRH stim test. And then to establish a pituitary source with the low dose dexamethasone suppression test, which in patients with Cushing's, they will not suppress, whereas in high doses, the 8 milligrams, they will suppress. And then the IPSS, I'll show a couple of charts on this in a minute. This is a very useful tool to establish pituitary source, and particularly in cases where the MRI is negative. And that's in about 20 to 30% of patients where the MRI will be cold stone negative, but there will be a tumor that resides in the pituitary. There are some functional imaging studies available, the methionine PET that's been used in some centers, where you can pick up very small lesions that do not show up on the MRI imaging. There are a lot of things that could mimic Cushing's, and it's very important for a surgeon to be mindful of this. Things like cyclical Cushing's, incidentalomas, ectopic adenomas, and pseudo-Cushing's. And 16% of the population at large will harbor a microadenoma. So just because there's a microadenoma doesn't mean it is the microadenoma. That's a very important thing to look out for. So the issue of an IPSS, this has been a very useful study. It's been around for decades now. And the principle is that you measure the effluent of ACTH coming from the anterior pituitary gland and compare that to the periphery. And then you take baseline and then post CRH stim, like you see in this graph. And in a patient who has an ACTH adenoma within the gland, you have this spike following CRH, indicating that the lesion is probably in the right side of the gland. And in this case, you can see that there's very little difference between the left side of the gland and the periphery. So on the basis of this, even in the setting of a negative MRI scan, a surgeon can go in to explore the gland, looking for a lesion within the gland, preferably in the right side. Here's a case from 2 weeks ago that I operated on here, and you can see this is a case where both sides, both the left in the pink and the right in the blue, both showed stimulation following CRH stimulation at point 0. And so in this kind of a case, it makes it more challenging to go and explore because the lesion could be just as well on the right as on the left. And in fact, on exploration, I did find an adenoma on the patient's right side, and the prolactin is used as a reference level, indicating good placement of the catheter. And this is the raw numbers. So an IPSS is a very useful study. When it is positive, it can be difficult to interpret when it does not localize, and sometimes you get false localization based on venous anatomy. I listed here the series of therapeutic options for Cushing's. Fair enough to say that the number one and the best by far treatment for Cushing's is surgical exploration, resection of an adenoma. And if you do that, the patient will go into remission, and that is the most durable and the most effective means. However, we do know that not everybody goes into remission. Some patients, for whatever reason, either because the adenoma is not found or they have an invasive tumor, will require adjuvant therapy. And you can see here from the list of medications, whenever there's more than one medication for a disorder, you can probably figure out that that means that there's not one best medicine. There are several options, and in the case of Cushing's, there are. Ranging from neuromodulators in this group to biosynthesis inhibitors that cut into the synthesis of the cortisol itself, those that block the cortisol receptor, such as mifepristone, somatostatin receptor analogs, and then this new fellow, osilodrostat Utresa, which is a biosynthesis inhibitor. And when medicine when surgery fails, stereotactic surgery is another excellent option to consider, and medicine can be used as a temporary bridge until that works. And then finally, if all else fails, there's the BLA or the bilateral adrenalectomy. So what what's the fair market value for results of Cushing's series? And on these next two slides, there's a variety of series that I've taken out from the literature. And I will tell you that one of the things in terms of interpretation of these series that's very important to keep in mind is the definition of remission. The definition, as you can see in this column here, varies from author to author. Some define remission as a cortisol of less than 5. Others say it's less than 2. Others say it's less than 2 plus a low-dose dexamethasone suppression test that indicates remission, and so on and so forth. But it's fair to say that the numbers probably range from about the mid 60s to as high as the low 90s. So in general, it's somewhere in that ballpark. And these two panels basically illustrate the range of series out there. And you can see most of the series as an N of somewhere around 100 to 200. Now, in our shop here at Emory, here are the criteria that we use. We use an AM plasma cortisol of less than 2 micrograms. And typically we monitor that in the first day, second day, third day, and so on until the patient reaches a nadir of 2 micrograms or less. And then after that, we'll get a 24-hour UFC, and then the patient will be discharged on hydrocortisone supplementation. And then post-op, as an outpatient, they'll undergo the rest of the dynamic testing to cinch down the fact that the patient is in remission. And I always tell patients and my residents is that the beauty of surgery for functional tumors is that you can assess success to within a decimal point. It's that precise. And so, and I think very important for the surgeons in the audience to remember that the benchmark is very, very, very stringent, and that's what we have to adhere to. The timing of post-op retesting is usually within the first few days, as I said, and then we repeat the full panel about 3 months, and then thereafter on an annual surveillance as long as the patient remains in remission. Here's our series. This is the patients in the yes column are those that went into remission after surgery, and in the no column are those that did not go into remission right after surgery. You can see for us we're about 84% induction of remission in cases of primary transsphenoidal surgery at Emory. There are some things in red here that affect and can are consequences of lack of going into remission. For example, almost 30% of the patients who did not go into remission had some form of cavernous sinus invasion. Patients reach nadir within a few days, so it's not a long hospitalization to detect whether or not the patient has gone into remission. And if you find an adenoma on pathology, chances are that the patient will go into remission if you get a gross total resection, whereas if you do not, then it makes it less likely. Here's our patient flow chart. I'm not going to go into that detail. This is the details of our outcomes of surgery, and I mentioned before of this series of patients, 91, 85% went into remission, and those that did not and recurred were treated in a variety of ways. So what are the options for persistent or recurrent disease? First of all, you have to make sure that you've done that postoperative assessment to determine remission early. The most common cause for lack of remission is either incomplete removal. In other words, you got 80%, 90%, but that 10 or 15 or 20% is still there. Or the patient had an undetectable tumor, a negative MRI scan, a negative exploration, and negative pathology. So that makes it less likely that you're going to get a remission. Patients with dural or extracellular extension into the medial cavernous sinus, the lateral cavernous sinus, and so on, are also patients that are less likely to go into remission. And if the patient is not in remission, and the best time to go in, if you have to go in for secondary exploratory surgery, is as soon as possible, whilst your memory is fresh, the field is fresh, and there's less scar tissue, and so forth. And of course, if surgery is no longer an option, then medicine or radiosurgery, or in the last effort, adrenalectomy. So the three major groups of medications are those that work on the ACTH tumor itself, somatostatin receptor, glucocorticoid synthesis inhibitors, and then the receptor antagonist itself. So the first group of drugs obviously reduce cortisol levels, but also have positive effect on tumor growth. So pasireotide is the standby for that. Glucocorticoid synthesis inhibitors will reduce cortisol levels because they impede synthesis of cortisol. and then the receptor antagonists will actually show elevated levels of cortisol because they basically affect the receptor. So these are the drugs that are in these categories that are approved for Cushing's disease. This is the newest of them. It was approved just in March, and it's an oral reversible inhibitor of cortisol synthesis. We have a patient on this at the present time in our institution. It works very well, and it's relatively well tolerated compared with some of the others. So radiosurgery, when it is necessary, or if it is necessary, has a very good track record in Cushing's. I think of all the functional tumors, it probably has the best for Cushing's. The lag time is somewhere around a year and a half to 2 on average. There is some concern for hypopituitarism. So we typically will advise patients, particularly women who are desirous of fertility, prior to undergoing that, to store some eggs so that they can sort of preserve chance of fertility. And in general, tumor growth is not a real concern with Cushing's disease. It's more of the effects on functionality. So what are some take-home lessons from Cushing's, that, at least from my standpoint, that I've learned? First of all, I would say make sure the diagnosis is absolutely secure before you operate. This is not an anatomic disease. It's not about mass effect. It's in general. It's not about the size of the tumor in general. It is about the biochemical aberrations that result from Cushing. So make sure the diagnosis is correct from a biochemical standpoint. I think it's always important to explore the gland carefully and completely, even if you find a tumor immediately. Don't declare victory just yet. Make sure you've done the job completely, because 89%, 90%, 95% is not good enough. It's only good enough when you have 100% resection. And I think it's important to reassess surgical results early and rigorously. I mentioned already that these tumors and these disorders can be measured to within 1 decimal point, if not 2. So there's no reason not to be rigorous in the assessment of outcomes. So the laboratory data and the clinical assessment of the patient is the major criterion for remission, and not the MRI. Go back early and re-explore if the patient is not in remission. I know it can be difficult as a surgeon to admit that, but just park your ego, go back and take a look and make sure you get the job done. Patients require lifelong follow-up and monitoring because recurrence can occur. I saw a patient about 3-4 years ago, had been operated somewhere else and had a recurrence of Cushing's at 22 years and counting. So it's not over until it's over. Most patients do not need any intraoperative or preoperative coverage for steroids. And sometimes people want to do that, but it's not necessary. They're making enough steroids on their own. I've learned painfully that they have a higher propensity for DVT. So we put our patients on aspirin postoperatively because of that risk of DVTs. And I also learned that if the patient doesn't crash, in other words, you don't get a significant phenotypic response, with appetite, blood pressure, blood sugar, that sort of thing, then probably is not a cure. And IPSSs are useful, helpful, but you've got to be cautious in their interpretation because you may be misled. Okay, so that's one of the first of the big 3. The second of the big 3 is acromegaly or gigantism.
Nelson, sorry to interrupt you. Just maybe you can do it a bit more briefly because we're closer to the time.
Okay.
So thank you.
So this, of course, in adults, we mostly see the acromegalics, and the syndromes already. The diagnosis is made by your plasma IGF-1 levels and confirmed with an OGTT. This is the mortality the mortality curves for patients with hypersecretion of growth hormone. And you can see here that you absolutely need to have reduction of growth hormone levels to restore mortality risk to where it should be. These tumors are commonly invasive at the time of the diagnosis. And look at this. These are all growth hormone tumors. Erosion into the clivus and the sphenoid sinus through the cellar floor, even where there's no supracellular tumor, bilateral cavernous extension, and this sort of lesion and a NUPS4 lesion here. So generally speaking, if you see a functional tumor with this kind of an MRI scan, it almost certainly is an acromegaly. The options, surgery is the first line, just as with Cushing's. There are a number of potential medical options out there, somatostatin analogs and dopamine receptor agonists and growth hormone receptor antagonists. And newest on the line is oral octreotide. And for those that fail those, there's the radiosurgery and the FSR. Long-term remission is predicted by patients who do not have cavernous sinus extension and have lower levels of growth hormone below 40 going into surgery. This is a complex chart. I'm not going to go into it in detail, but this is the current flow chart for guidelines from the Endocrine Society for Management of Acromegaly. And you can see that for the most part, surgery remains the mainstay. The criteria for biochemical remission in acromegaly has undergone evolution over the last 20 years. It used to be you had a growth hormone less than 10 nanograms and the patient was deemed to be in remission. Today, it's a fasting growth hormone less than 1 nanogram per mil and an a growth hormone of less than 0.4 following an OGTT. So the bar is very, very high for surgical or remission. These are a range of case series from the literature, and I will caution you that most of these case series that are in existence in the literature were done using the previous criteria for remission. So essentially, they're meaningless in today's world. Medical treatment, I've alluded to that. I'm going to skip that over. These are the current treatment options for acromegaly in terms of medical management, and I'm not going to go into those details here. The two mainstays that have been around are the octreotide and lanreotide. Both the dopamine agonists, bromocriptine and cabergoline, are not FDA approved, but are utilized in acromegaly, particularly in patients who co-secrete. We've learned just recently that these drugs are not benign, as benign as they used to be thought. They can cause problems with valvular disease if taken in too high doses. Pegvisomab is the receptor antagonist, and the important thing to note here is that whilst you're on pegvisomab, your IGF-1 levels can drop, but the patient's growth hormone levels will be high. So we talked about the oral octreotide. This has been a boon for patients because it used to be that you have to get shots, either daily shots or monthly shots, and now we can transition patients to oral medication. Radiosurgery is an effective alternative for patients with growth hormone secretion. It's recommended according to current guidelines if medication is insufficient to control either hypersecretion of growth hormone or tumor progression on the medications. So those are the indications for it. So lessons learned in acromegaly: use breathing trumpets in patients with acromegaly. They get into trouble very easily with breathing. The bone is thicker, the blood vessels are larger, carotids tend to be more tortuous, the distances for surgery are greater, and intubation and airway management are problematic and need to be taken very, very seriously. And there are concerns about this going in preoperatively. It helps if the patient is treated with medication for a few months before going to surgery. Okay, the last of the big three is the prolactinomas, which are actually the largest group of functional tumors for sure. They're most commonly seen in women and usually microadenomas, and in men they're usually macroadenomas. Both genders are exposed to large, long-standing effects of prolactin, such as fertility and osteoporosis. There are a variety of non-tumoral causes of hyperprolactinemia, which I will not go into this in detail, except to say that the major offenders are medications. And of course, the number one, of course, that everyone should keep in mind is pregnancy. The range of hyperprolactin secretion and can overlap between tumors as well as other causes. So be careful about that when you look at the levels. Make sure that you get that looked at very, very carefully by your endocrinologist. There is still something called the hook effect. So just as a matter of caution, just because the levels are low doesn't mean that they are low in reality, and it helps to get dilutions. And you can see on this graph the general spread between the tumor size, there is some correlation between tumor size and prolactin levels. And when you start seeing prolactin levels in the thousands range, you almost certainly that there is evidence of invasion. The current guidelines continue to recommend medical treatment as the first line of treatment, but I think there's been some change in that posture, and I'll mention some of those in a minute. The two first line drugs are either bromocriptine or cabergoline. Cabergoline much more comfortable for people because it's only a couple times a week. And in addition to prolactin levels being normalized in the majority of patients, tumors can also undergo significant involution, as you see in this particular photograph. And in those cases, they obviate the need for surgical decompression. I would caution you that there is insufficient data to support withdrawal of medication, even in the face of the positive biochemical and tumor response. We've learned recently that these drugs are not as benign as we think, and if you are faced with patients undergoing escalating doses above 2 milligrams a week, you should be cautious and be sure that those patients have their valves looked at. And I think a lot of endocrinologists have become more attuned to this over the years. In men, we tend to see more of this phenomenon, these invasive macroprolactinomas that destroy the skull base, chew up the bone, chew up the dura. And when you put the patient on medication, for example, they will get a spinal fluid leak. And this is a case in point such as that. And this patient came in with a prolactin of 60, but when it was diluted, it was 38,000. So it illustrates that point. So what are the current indications for surgery, which they are? Patients with cystic prolactinomas, we've learned that those don't respond very well to medication. Patients in whom the prolactin falls but doesn't normalize, or that there's a dissociated response. In other words, the prolactin level normalizes, but the tumor does not go away, doesn't shrink. Patients who develop CSF leak during the drug therapy, or apoplexy, or patient choice. So there's still a significant role for surgery. Let me move quickly through this. Radiosurgery is rarely required for prolactinomas in our hands, and I think in most people's hands. And it turns out that the results of radiosurgery for prolactinomas are not very good compared with, say, Cushing's, for example. Lessons learned in prolactinomas, always ask about pregnancy. Don't get fooled, don't get caught, or medications that might themselves interfere. Always get dilutions. Start your medication slowly, because that way you don't run into side effects quickly. Some patients may have persistent hyperprolactinemia after surgery. Sometimes that's due to stalk perturbation. So it's not always due to tumor residual. The last two I'll mention just very briefly, the TSH adenomas. These are rare. They occur both in men and in women, and they typically will present with hyperthyroidism, and they're associated with co-secretion of prolactin and growth hormone. Most of them tend to be macroadenomas. Sometimes they're discovered incidentally, sometimes because somebody has measured an alpha subunit that's elevated, and that leads to the detection. The standby is for treatment is surgery, and there is medical management for those that do not get cured at the somatostatin analogs. And then finally, gonadotropin secreting adenomas. These are also very rare, even rarer than the thyrotropes. They result in obviously ovarian hyperstimulation in women, and the first choice of treatment for them is surgical resection. So I'll make a last few comments about surgery and techniques, and then I'll hand it off. Surgical position for transsphenoidal surgery, supine with the chin horizontal, neck neutral for sellar lesions, extension for anteriorly placed lesions, and the head rotated 20 degrees. So this is your classic position for transsphenoidal surgery. Endoscopic instruments need to be low profile, non-bayoneted, so that they can follow the endoscope in an appropriate length for extended approaches. I like this tool. This is it's called a spyway, helps protect the mucosa from perturbation, particularly the septum and the turbinates when you're bringing instruments in and out. So it's a very nice tool to have. The steps in surgical approaches I've listed here. I'm going to skip those in the interest of time, and I will go into the videos in a minute. The major surgical strategies are wide opening of the sella, access to the whole gland, and as I said, it's a selective adenomectomy in functional tumors that you're looking at. Selective adenomectomy is the key. Here's your typical rodent photograph that shows the relationship between the gland and the critical structures surrounding the gland, which must be well preserved. So a selective adenomectomy means preservation of the tumor pseudocapsule. This is from Jules Hardy's classic description of a selective adenomectomy. This is an adenoma, and that's the capsule around the adenoma. And you can see that there's a clear distinction between the tumor and the pseudocapsule. And if you stain this with reticulin, you'll see that beautiful demarcation between an adenoma and the pseudocapsule. So this is a case of a patient with Cushing's disease, a pediatric case with Cushing's disease. And you can see the tumor right there where the tip of my arrow is, and the gland is below here. And what we're doing here is a careful dissection around the tumor nodule, taking great care not to breach that tumor nodule so that you get a gross total resection, and you enucleate, that's the word for this, is to enucleate the adenoma just as you see here. Here's another case, another patient with a microadenoma, Cushing's microadenoma in the left lateral aspect of the gland anteriorly. And here's the video of that case. Here's the tumor right there. And what we're doing is we preserve the margin between the tumor and the gland. The gland is to the patient's right, my left. And we're circumnavigating the tumor, taking it away from the medial wall of the cavernous sinus, coming around it posteriorly and anteriorly. And we'll continue to prosecute that until we get around the entire tumor 360 degrees. And notice that there's no attempt to breach the tumor pseudocapsule at all whatsoever. And the goal here is to enucleate the tumor en bloc so that you have a gross total resection, and the patient stands a reasonable chance of going into surgical remission. Up here is your arachnoidal margin there. And as you'll see in a moment, we'll continue to do that, and tumor will be delivered. And there it is. So this is the strategy that is used for these cases. Here's a last case, and this is the last case I'll present before I hand it off. This is a patient with a microadenoma, and this is done with a 3D endoscope. And of course, you can't see 3D, you can't see it in 3D right here, but this is a case where we have an adenoma buried at about 2 o'clock in the anterior superior margin of the gland, right about there. You can't see it from the surface. You have to peel off the anterior wall of the gland. The rim, that tiny rim of compressed gland, has to be peeled off to unearth the gland, the tumor below the level of the gland. And then you have to then circumnavigate that again in the same manner that I've shown in the last 2 slides. So the best chance, finally, the best chance for remission of a functional tumor or cure is the first time. That's the best time. Repeat surgery is always more difficult and certainly should only be done in experienced hands. An unnecessary, avoidable repeat surgery is costly to the patient in excess morbidity and worse remission rates, and costly to the healthcare system. There have been clear-cut volume outcome relationships and outcome volume complication relationships that have been shown. And so it's very important that we do our very best to make sure we deliver the best outcomes with the least likelihood of complication and the highest success rates to our patients. Thank you very much.
Thank you, Nelson. That's fantastic didactic and everything for the functional tumors. So we'll move on directly to Eduardo, who will talk about the invasive tumors in general. So Eduardo, if you can
yes, share my screen.
load your screen, yeah.
Yes, good night for everybody. Max and all the panelists. It's a very, thank you for this kind invitation. And congratulations for you and your team, because this weekly webinar takes some new knowledge, and we can start getting more knowledge during this pandemic. And also, I'd like to say that after this talk of Dr. Nelson, is very responsible, great responsibility to what I'm going to talk here. This outstanding lecture from Dr. Nelson. I'm going to talk about invasive pituitary adenoma, what we can do, how to handle invasive pituitary adenoma. And this is also a teamwork, work for almost 30 years with Dr. Aldistam, with Suburb ENT. And we have been doing this together for the last almost 30 years. I have no conflicts. And I will bring to you to discussion this is a very good paper from Brescia, from Piero Nicolai from Brescia. It's a meta-analysis about invasive pituitary adenomas. And they found in this meta-analysis that they represent between 2 and 3% of all the pituitary tumors, and most frequent are non-function and silent cortical trough adenoma. And they put in discussion what is invasive, what is an aggressive pituitary adenomas. So what's the difference? Are the same thing? And this is very difficult discussion, because if even we go to the lexicon, if we go to dictionary, invasive and aggressive has almost the same meaning. So I think we cannot separate those two words for the pituitary adenoma. So we are going to get, say, about invasive tumors. How we consider pituitary adenomas as an invasive tumor? Well, we can use 3 criteria: radiological, histological, and surgical criteria. And we must see that most of the results, they are not congruent. Maybe we think it's invasive in the radiologic, in the MRI, in the OP, we see that's not invasive. We can see that histological is invasive, but the clinical course does not seem to be an invasive tumor. So from the radiologic criterion, the first thing is tumor must be beyond the limits of the cella and probably breaking the anatomic barriers. Tumor that goes beyond the cell in breaking anatomic barriers would be a radiological criterion of invasive. Size is not a matter. This is a large invasive tumor. Everybody says it's invasive, but also microadenoma, GH producing adenoma, can invade in this case, the cavernous sinus. Another thing that we must discuss about invasive pituitary adenoma is really an invasive tumor, or is extension through natural pathway. We'll go back to this paper of Kawase in 1996, and he showed in 1996 that the limits of cavernous sinus between some structures are very thin and fragile membranes that was very easy to trespass by the tumor. And we can see here, as he had showed in oculomotor nerve, this fragile membrane here, between cavernous sinus and gastric ganglion, and between cavernous sinus and the pituitary body. Those are ways and paths for the tumor to grow, even for tumor if it's not very aggressive or invasive. From radiological criteria, Hardin in 1976 said that grade 3 and grade 4 were tumors that cause cellular erosion, not only cellular enlargement. This is It's a large tumor in the sphenoid sinus, but the cellar is enlarged and not destroyed. Different from this patient here, prolactinoma, with a tumor in the clivus with such a large bone destruction. Wilson 84 said that invasive tumor are tumors that have an asymmetrical paracellular extension, grade D, supracellular asymmetrical, or grade E in the cavernous sinus asymmetrical. This, in his classification, this is not an invasive tumor, and this is invasive tumor. And the most used grades for is the Knosp classification for invasion of the cavernous sinus, when he considers the grade 3A superior, 3B inferior, and grade 4, 36 degrees around the carotid artery, the tumors that are invading the cavernous sinus. From the histological point of view, classically, we have dural invasion and some proliferative index studies to show Ki-67 to show in the pathological examination if the tumor is invasive or not. And there are new studies about some proteins that would give some invasiveness characteristics of some of those tumors. But even those studies, molecular studies, are not so trustful because they not are parallel with the clinical course of the tumor. I'll show these patients a recurrent GH tumor operated 22 years ago and not in remission. You have tumor here in the cavernous sinus around the carotid artery, and we operated this patient. And this is the Doppler. We open the dura, this membrane. This is the tumor, very soft tumor, and try to separate as much as possible of this tumor from the carotid artery here. We dissect the whole carotid artery in order to lower the volume of the tumor. We then do some radiotherapy, complementary treatment. And you see with Ki-67, 1%. Invasive tumor in cavernous sinus, Ki-67, 1%. And after 4 months, we found this tumor in the craniocervical junction. This is a PET-CT, and we operated, and this was a pituitary adenoma GH protrusion in the craniocervical junction. That would be classified as a pituitary carcinoma with a Ki-67 of 1%. So the invasive tumor is very difficult to determine. From a surgical point of view, we must say that with the endoscopic wide view that we have endoscopic approach, give us the opportunity to be more radical in those invasive tumors, that we can go upper, lower, and lateral to the pituitary body. When the tumor goes to the inferior invasion, to sphenoid sinus and clivus, and this is a prolactinoma, just like Nelson has showed, with bone erosion and all the cranial base invaded by the tumor, from prolactina around 18,000, and with carbagolina goes to 1,500. But he developed a CSF fistula when we took him to OP, and this is the pictures of the OP, the cavernous sinus full of the sphenoid sinus full of tumor, and this after part of removal, the gland, and then the diaphragm of the sella, and this is the clival dura, and this is a small hole in the clival durus that was responsible for the CSF fistula, and there's the final view of the surgery, and the prolactin level after third day from 1,500 to 350 in 3 days. Of course, we did not cure this patient. He will have to stay with cabergoline, but we can lower the prolactin level when we take low volume of the tumor. For the supracellular invasion, the endoscopic approach, we can use the extended tubercle transplantum approach. And he opened a new possibility in very large tumors. These are giant tumors that invade the sphenoid sinus, the nasal fossa, and the anterior fossa with a cystic part. And without endoscopic, we would probably do in two-stage surgery. But with this cystic part, upper cystic part, we try to go, maybe we can remove from the pure transsphenoidal approach. And this is what we see, the nasal part of the tumor, tumor in nasal cavity, and remove the tumor in nasal cavity. And then we open the dura of the planum here. It's very soft tumor, and we can do this for soft tumor. For hard tumor, it would be very difficult. And then we try to separate the tumor from the rest of, from the frontal lobe. And here, and we will see the structures. Frontal lobe, we will see here the optic nerve, optic carotid artery, left optic nerve, carotid artery, and the tumor we can separate, and then debulking the tumor more and more, separating the frontal lobe, and then in the deepest of the operating field, we see the arteries from the anterior communicating or anterior cerebral artery complex, separate the tumor from the arteries. This was not so difficult to separate. It was a very soft tumor, suckable. And then at the end, we can remove almost the whole tumor from the transnasal transplantum approach. So we have from endoscopic view, you can see the corpus callosum and all the pedicallosa, callosum marginal, in the interhemispheric space from a transnasal approach. So this patient, we could solve his problem only with one-stage surgery transnasal. And these are the MRI postoperative. This is fat. We filled with fat, fascia, and flap. We call the 3F technique. And this is also invasive tumor, grade E from lateral extension. We always say this old video, but the first one, we use a transplant approach for pituitary tumor. And we said to the patient, okay, we go transnasal. If the tumor is soft, then we extend the approach and go a transplanum approach, tubercular transplanum. And that's what happened. This is the cellular tumor. The intracellular tumor are very soft. So after removing the cellular portion, we extended the approach for a transplantum, and we could see and remove the tumor from the supracellular cistern. As you can see here, the optic nerve, the superior epiphyseal artery. There were tumor lateral to the superior epiphyseal artery, but very slowly we could remove this tumor, as you can see here, preserve the artery. And at the very end, we were able to see even the temporal lobe from a 45-degree endoscope from the transnasal approach, and closing with fat, fascia, and flap. And this is the postoperative CT, was a non-function tumor. We have seen already, they have almost more than 10 years of follow-up without recurrence. When the invasion is to the cavernous sinus, is very interesting because the tumor goes to the cavernous sinus, and this anatomic view is not what we see in the surgery because the tumor push and displace the nerves laterally. So we have space in the lateral space of the cavernous sinus, lateral carotid artery, to work and remove the tumor. As you can see here in those pictures, this is the carotid artery, this is the medial wall cavernous sinus, and this is the sixth nerve, and this is the space that the tumor has created. It's possible to remove tumor from lateral to the carotid artery. It's the same thing, sixth nerve and carotid artery here after removal of the tumor. The problem is, does it worth to operate, or is better to do radiotherapy in cavernous sinus tumor invasion for secreting tumors? And there are some papers from radiosurgery. We see endocrinological remission between 40 and 60%, and some papers on surgery, endocrinological remission around 47%, almost the same result. So things that we must take and talk to the patient and see what we do. So our philosophy today is all the secreting pituitary adenomas with invasion of the cavernous sinus, we try to remove, we try to follow tumor, and we try to get into the cavernous sinus to get a more radical removal. And all the recurrent and large non-function pituitary adenoma also with cavernous sinus invasion. How can we get into the cavernous sinus? We can go just follow the tumor path in a transcellular approach. Then we can go in front of carotid artery, we can go behind the carotid artery, and depends on the extension of the tumor, we can go lateral to carotid artery. Or we can go more lateral through a transpterygoid approach, and we can have more lateral space to work in the lateral space of the cavernous sinus. How we decide between one and the other? First, the larger of the lateral extension. The larger lateral extension, more lateral we must go. And here, also this sagittal view, we can see how much tumor is in front of the carotid artery. So if we have this view, it's very easy to open this membrane here, and through the passing anterior to the carotid artery, you can go lateral to carotid artery and posterior. When you don't have the tumor be in front of carotid artery, this is more difficult. Maybe you do a pterygoid approach. These are patients that we told her we would not take tumor from the cavernous sinus. Probably we were not, was not what we wanted in the surgery, but it was very soft tumor. And we opened, we removed tumor, and the lateral walls was totally open, and we just follow a very soft tumor. So we could follow lateral to the carotid artery. This is carotid artery. Lateral, anterior, posterior. This is the inferior hypophyseal artery. And we could have a very radical removal. And this is the sixth nerve laterally displaced. And this is the postoperative MRI. This is an interesting case because it's GH producing tumor. With this lateral extension, grade 3A from kinosp, and we removed the cellular portion, we saw some small opening in the lateral wall of the cavernous sinus. And through this opening, we follow this open, and you see that there will be some tumor coming from the cavernous sinus through the small open. We enlarge this open till we get some bleeding from cavernous sinus. And this patient from GH from 14 comes from GH of 0.7 after this surgery is till now, after 2 years, under remission. This male with a silent ECTH tumor, recurrent, we always try to go medial and lateral, but sometimes we are not able. This is a recurrent tumor, and you see that we found the carotid artery, we removed tumor medial to the medial wall, medial to the carotid artery, but you can see there's a lot of adherence and fibrous tissue around the carotid artery. So we had to stop the surgery and say, we don't go lateral to carotid artery. The consistency of the tumor or the fibrous, postoperative fibrous, normally our patients with recurrent tumors, is very important. The transpterygoid approach is more invasive when we called about the function of the nose. we must do a homolateral maxillectomy, removal of middle turbinate, coagulate the sphenopalatine arteries, and use the contralateral nasal flap. And the center of the field is not anymore the pituitary, but is the carotid artery and median nerve. This is an example of the patient with recurrent non-function pituitary adenoma with large extension of the cavernous sinus. So this is the transpterygoid approach. This is maxillectomia omnilateral, same side, coagulation of the pterygoid arteries. So we have lateral space, as you can see here. This is midline, and this is lateral, the cavernous sinus lateral to the pituitary gland. First, we remove tumor from the medial part, and then we open the lateral parts very safely because we have seen that there is that the tumor is in front of carotid artery, and the carotid artery is pushed posteriorly, very soft tumor. So very gently, we try to remove, dissect, and aspirate the tumor as much as possible. Of course, we can say there is not it's a gross total removal, but there's some microscopic disease. And at the end, this is the middle part. And at the end, what we see is the carotid artery, 6th nerve, lateral displaced, and without, we see a gross total removal of the tumor. There are some cases that the tumor, by classification, doesn't go into the cavernous sinus. There's not invasion of the cavernous sinus. And this is a recurrent prolactinoma and resistant to cabergoline. And you see this the pituitary gland, and we came here, and the tumor is lateral, it's just attached near the carotid artery. And what we see here is the tumor was just adherent and attached to the medial wall of the cavernous sinus. Not into the cavernous sinus, but attached to the medial wall of the cavernous sinus. So we had to remove the tumor and the medial wall of the cavernous sinus, as you can see here. And we see the dorsum cellular posterior, and this is a intercavernous carotid artery here. This is a final view, a very radical removal. So the tumor did not go into the cavernous sinus, but we had to remove the medial wall. And this is the result, prolactin after the surgery, without any medication. Almost the same case, but Cushing. This patient was operated with Cushing, with remission for 6 months. After 6 months, clinical recurrence, but without any MRI sign of tumor. Then we wait almost 1 year. Then after 1 year, we could see the tumor almost the same, very close to the carotid artery, not inside the cavernous sinus. And we have done the same approach, take the tumor, a very lateral approach, very lateral, wide open of the cella, and the fibrous tissue with tumor. And this is the gland. So you try to find a plane between the gland and the tumor. And here the dorsum cellular, and opening of the cavernous sinus, this is carotid artery, and remove as much as possible all the dura, not only the medial wall of the cavernous sinus, but as much as possible the dura in front of the carotid artery. This is the patient after the surgery with normal cortisol, midline salivary cortisol. She had a transitory 6th nerve palsy for about 2 or 3 weeks, probably due to spongostan that we use of a high pressure we put in the cavernous sinus to stop the bleeding. And those are both patients almost with the same final view of the removal of a medial wall of the carotid cavernous, medial wall of cavernous sinus. And Nagata has showed that almost 60% of the patients, especially recurrent tumors, have infiltration of the medial wall of the cavernous sinus. Another special case with tumors that go into the cavernous sinus, invasive tumor, are those tumors that come to the cavernous sinus and get out of the cavernous sinus in intradural space through the oculomotor triangle as this patient, also a recurrent tumor. no secretin. And as you can see, a transplano approach here. We see the diaphragma cella, optic nerve, and the tumor, extension of the tumor in the intradural space. And we could see some nerve fibers here, very adherent to the tumor capsule. So we decide to debulk the tumor. And after debulking, turn the tumor and remove all this upper part of the tumor capsule, but we left some tumor capsule adherent to some small nerve fibers, as you can see here. And this is the third nerve with tumor capsule. And the patient, of course, developed a third nerve palsy after surgery. And this is the postoperative MRI. And this is the patient after 1 year have an almost total recovery of the third nerve in the horizontal gaze. So as long as it's to go further and radical removal, after 1 year, he had almost a normal third nerve palsy. And this is described by Juan Miranda in this nice paper that said those tumors that come through the oculomotor triangle from in the cavernous sinus. And then we come back to the paper of Kawase that showed this tiny membrane in the oculomotor part of the limits of oculomotor nerve and the cavernous sinus where the tumor gets into this triangle. Some pitfalls. So we said every secreting tumors that go into the cavernous sinus, we try to remove what we cannot remove in all of them. This is a recurrent macroprolactinoma resistant to cabergoline. We told the patient we try to remove as much as possible, then do radiotherapy. But the tumor was very vascular, very hard tumor. We could remove only the medial part of the tumor. So we didn't get any advantage of the patient for this surgery. And also, when we try to go more radical and remove more radical tumor, we take more risks. And this using bad instruments, not appropriate instruments, we can have some terrible complications. It's like this carotid artery injury because of this coarse diamond trying to go very lateral to expose the tumor in the cavernous sinus. So in conclusion, about invasive pituitary adenomas, we can say that from a radiological point of view, Hardy grade 3 and 4, Knox grade 3 and 4, Wilson grade D and E for superior, inferior, and lateral extension. From a histological point of view, dural invasion and proliferation index to say about invasion. And from a surgical point of view, in our philosophy is try to remove all the non-prolactinin secreting tumor or prolactinoma secreting tumor invading the cavernous sinus, large non-secreting tumor. We think that transnasal endoscopic surgery is more effective than the microscopic. We use transplantal, transcellular, or transpterygoid approach. Those three approaches depends on the tumor extension, and tumor consistency is the most plays a biggest role on how if you are going to get a radical removal or not. We need more data to compare cavernous sinus removal, surgical, and with radiotherapy or radiotherapy alone. But we are sure that we combine treatment is always more effective for those patients. Thank you for your attention, and we can discuss.
Eduardo, I think this was a spectacular lecture, really beautiful, and I'm sure everybody in the audience enjoyed it, and those who are not with us today will be hearing the recorded versions as has been in previous sessions. Thank you. I appreciate very much the effort in putting this lecture together. I'd like to invite Roy Cassiano, my rhinology colleague, to teach us how his preference, what his preference is about rebuilding the floor of the cella and the anterior skull base after it gets destroyed.
There we go. Let me unblock my mute. Hello, everybody. Thank you. This is been a very informative session, especially for an ENT doctor to listen to his colleagues in a kind of a nice formal setting like this. Nowadays with COVID, it's very unusual for us to meet, but when we do, it's great to share this knowledge. In less than 10 minutes, Jock wanted me to review a little bit about our technique, specifically at UM, and it's a pretty unique technique. And I'll go into it in a second. This is, it was said that it's important for institutions to do these type of surgeries to review their results, not only because of what kind of surgical complications you have, but also medical complications. This is just one of our last series that we did through 2012 and 18, looking at a number of patients who underwent pituitary surgery. And we can see that, and we were looking specifically at readmission rates. We're looking at both the surgical readmissions and medical and the reasons why. And Dr. Karji will talk a little bit about the medical issues, one of the most common medical issues. But you can see that we had a total of we had about a 14% readmission rate. It's important to know this number. And between the medical and surgical, you see the medical reasons were a little higher than the surgical reasons for readmission. And hyponatremia was actually one of the highest reasons medically for readmission, whereas CSF leak repair was at 3.4. Now, this number hasn't really changed much in the over 20 some years that we've done surgery together with Jock and myself. But I will review some of our techniques and some of the pitfalls and pearls that we've learned over the years. So here is a technique that we use and have been using. Of notice, this was one of our last article that we published in 2013, but the technique hasn't changed, and really our results haven't changed either. In general, it's still staying well around 3% CSF leak rates requiring admission. We do not put lumbar drains in any of our patients. So what you're seeing here in the actual results as far as CSF leak basically represents patients that we've operated without lumbar drains, we've sent home, and then they'd had a post-operative leak somewhere in the first few weeks after surgery for the most part. So the repair that we've done is basically a one-layer acellular dermis. Before acellular dermis was available in the 90s, when we started doing a lot of the anterior ventral skull-based resections for esthesials and other type of tumors, we still did a very similar repair. At the time, we had our tissue bank and we were using our freeze-dried dura availability. The freeze-dried dura was okay after you rehydrated it, but we found that when the acellular dermis products came into play in the late 90s, that it was easier to reform and reshape the acellular dermis to the surrounding irregular bony structures, that you can adhere them better. And so, but the technique is still the same, where we had, in the case of the pituitary, we have an inlay portion of the graft, and then we have an onlay portion, which is the part that is probably the most important part, which is this bony edge right here, where you've got to make that real tight wrap around the corner so you don't have CSF going through it. So to do that, you've got to have a way of pushing that eloderm inward a little bit where the tumor was, not to overfill it, but enough to create enough pressure in the pocket, where then you can just put on your gel foam over the onlay portion inside the nose, inside the sphenoid, circumferentially on the bone. And then you put gel foam, and then followed by a Maricel tampon. We've never used balloons because that is very painful and ulcerative to the nose. We've used Maricels most of the years we've been around doing this, that fills the space. It also, again, molds to the irregularities of that common cavity. So basically, as we put the alloderm, the size of the alloderm, and I'm showing this video specifically for a reason, I'll tell you in a second, but the size of the alloderm graft should be at least 2 times the circumference of the bony defect from one side to the other, at least 2 times the size. The problem is, in a case like this, which had a very small CSF leak, you can get away with a little smaller. You can see the concept is the same. You pucker it up, you push in these little plugets that we create that I'll show you in a minute that act like a little mini tampon inside where the tumor was, pushing the acellular dermis within the cella, and then you wrap the edges, make sure you have enough of an edge around it that you can wrap on its own onto the bone circumferentially. So you systematically have to go around pushing on the edge all the way around to make sure there's no dead space and that you have acellular dermis touching the bone. And then of course you put the gel foam, you can compress the gel foam with a cottonoid, and then you put in the tampon. The other thing is when you insert the tampon here, you try to only insert it where it's touching the gel foam, and then you put water on it to hydrate it, and then you push it in the rest of the way like an accordion, so it takes up the shape of the cavity. We refrain from pushing that alloderm while it's still hard up against the alloderm. It can displace both the alloderm and the graft. So once it's just barely touching the alloderm or the gel foam that's protecting the alloderm, then we hydrate it and we push the rest of the Maricel in there. And we take that out within 10 days to 2 weeks after surgery. So these are the little, we wrap some Surgicel around dry gel foam and just moisten it on the fingers to create these little cigarettes that we cut into little cylinders. Generally, you only need, and these cylinders are cut in about a centimeter size at most. And these are what we place inside, as you see here on the graphics. Inside here, generally you only need 1 and at best 2 cylinders. The key here is if you are doing the same similar repair for where you got a high flow leak and you see the third ventricle, the optic chiasm, not to overpack this so it doesn't migrate superiorly and put pressure on the optic chiasm. So you have to be very careful how much you put in there. As long as you got this wrap around the edge of the bone, that's all you need. You need the pressure around the edge. This is the most important part. This key part is the pressure around the bone here and killing the dead space. So this is another case here where we've finished removal of the tumor. We put in the acellular dermis, we redrape it. We like to have it so the dermal side, the punctated red side, is down towards the pituitary. And then we put in our cylinder, 1 or 2 cylinders, again, just to fill in where the tumor was. And then we compress it with a cottonoid. And then we make sure that we've redraped all circumferentially against bone, so there's no dead space in this area. Once we know there's no dead space, then we go ahead and place our gel foam. We compress it again to make sure again that there's no dead space. And then we put our Maricel to fill the cavity. We hydrated it, and then we push it in to take the form of this cavity, the internal part of the cavity. It does not fill the nasal cavity. It only fills the common sphenoid. So when do we use a flap? Because that always comes up. I know some of my colleagues around the country and their neurosurgeons like to routinely use flaps even for routine cellas. We'd like to save it for a rainy day if we really do need it and not overuse it on these patients. Just a little side, this is an article from 1989, a year after I finished my residency. And in those days, they were doing reconstruction of rhinectomy areas with a nasal septal flap where they would line the internal lining of the external nose as they reconstructed the cartilaginous subunits of the nose with cartilage from elsewhere. But this is nothing new. The septal flap's been around for ages, at least since the 80s, early 80s. But what is new is that we've been able to adapt this to repair the skull base. So this is one of the areas, if you have a high flow leak, I think that's made a big difference for us. And and this is a little old information now, but we noticed in an old review of our numbers that, and even nationally, you see literature that range from 15 to 40% CSF leak in these high flow leaks. And in most evidence out there, they've been able to decrease this to low single digits with the addition of the flap. For us, it's still the same reconstruction with the acellular dermis. The only difference is that before we put the gel foam in place, we placed the flap above it, and then we put the gel foam. So here we've done the alloderm reconstruction, high flow leak. We try not to over compress it up towards the optic chiasm. We redrape everything circumferentially, and then we go ahead and rotate a flap around it. And we, again, it's killing the dead space is very important. Another case here where we've basically have the optic chiasm. You would think this is one of these cases where you'd avoid doing anything that may compress this. People would put fat first. We sometimes will do that. We didn't in this particular case. Just a little note, when you have these big defects, it's important to overestimate the size of this type of graft, because you're going to have to really have a lot of bone against alloderm apposition intranasally in the sphenoid, more so than a smaller defect. So you need to overestimate, redrape everything, and make sure that when you put your little plugs in, that you don't overplug it high up into the up against the optic chiasm. Over time, that kind of resorbs and the graft will shift downward as it heals and it granulates in place. But here we're just putting the first plug. We put a couple plugs in this particular case, and then we would go ahead and put the second plug. We redrape the sides, and at this point, we would go ahead and place the flap right above it, which is basically what we did. At this point, these are the post-op views here, and you can actually see the flap on the sagittal plane. You can see a little flap on the floor of the common sphenoid. So in summary, just some pearls for larger anterior skull base or low flow defect. A graft really is all that is necessary, as long as you adhere to the fundamentals of closure, and that includes killing dead space. Make sure you have graft to bone apposition, and make sure that postoperatively you do not debride the grafted area. You let that fall off. We give our patients irrigation with saline irrigation starting a week after they've seen us for Maricel removal. The only reason we don't start it immediately after Maricel removal is to detect if they have a leak, because some of these patients come in, they start irrigations, and immediately they're calling our office that they've got a leak, when in fact what it is just accumulated saline in the sinuses. So we try to hold off doing that. And the goal is, again, to separate the intracranial structures, dura and brain, and create a watertight seal around the edge of the bony defect. That's it.
Thanks, Roy. Very clear, I think. Thank you very much. Again, if there are questions, we'll field them at the end. So now I'd like to invite Atil Karji, and after that, Alejandro Ayala, to talk about endocrinologic issues.
Okay, well, thank you for having me. I hope everyone can see my screen. Let me know if otherwise.
Yeah, it's very clear, and we hear you well.
Great. So I'll be very short. I think I only have about 5 PowerPoint slides, and I'd like to share my time with our other panelists. I'll review with you some work we've been doing with a quality improvement project to prevent, identify, and treat hyponatremia and prevent our readmission rates, which you heard a little bit about from Roy already, for hyponatremia. And I'll also just mention briefly that you may all realize this already, but pituitary disorders are a very small group of patients in an endocrinology practice, and not all endocrinologists may be experienced with some of the more challenging cases. So it's, I think, important for the neurosurgeons to identify endocrinologists in their area who are experienced with these patients. And so I'm going to talk a little bit about perioperative and postoperative steroid and especially sodium management, and point out that the glucocorticoid management and also DI and SIADH prevention protocols are very variable among different institutions, even in the United States and around the world. There are some places that operate on patients without steroid coverage and check cortisol immediately post-operatively on day 1 and day 2 and discharge patients. And similarly, there's other places that will send all patients home, as we do, on physiologic low-dose hydrocortisone and reassess cortisol levels and have the endocrinologist discontinue them within a few weeks after surgery when deemed appropriate. Sodium management is also quite similar. Historically, there were times where we wouldn't follow sodium levels very early after surgery, soon after discharge, until a couple of weeks after surgery. And there are other centers that are much more aggressive and put patients on a fluid restriction, liberalize salt intake, and check sodium quite early as an outpatient, and follow up very closely with the patients. There are really no controlled trials comparing the outcomes among these different protocols. And hyponatremia is indeed a frequent cause, if not the most frequent cause, of early and delayed readmission. So you're all familiar with this classical triple phase timeline, which has been elaborated upon historically by studies of experimental transection of the pituitary stalk. And what you see here in these red and blue lines on the graph are measurements of urine osmolality and serum sodium, basically as a surrogate of ADH production. So owing to injury, which is often temporary to the neurons in the pituitary infundibulum and neurohypophysis, we see an early phase here shown on the left of just a couple of days of diabetes insipidus, followed by a rapid change and a shift here that can last a week or two of SIADH, which can lead to hyponatremia if not intervened upon. And this is a very important reason why we don't send patients home, even if they do develop diabetes insipidus inpatient, on standing orders of DDAVP, as it should only be administered if absolutely necessary, if patients are having extreme polyuria or polydipsia. Otherwise, the risk of hyponatremia increases. I'll say that this pattern is classically described this way, but those of you who've seen a lot of these patients will notice that this is very variable. And we can see patients who just have one of these phases rather than all three or none of them at all. And so there is a little bit of literature, on the top left, a study from Andrew Little's group at the Barrow Neuroscience Institute in Phoenix, Arizona, just describing that delayed hyponatremia is a common cause of readmissions. They found around 8% of patients undergoing transphenodal surgery were readmitted. And on the top right is a study from England from an endocrinologist well known to us, Ashley Grossman, who tried to identify causes or predictors of who would develop hyponatremia. And there's several papers on this, and they have contradictory and inconsistent findings. So I'll show you our data on the last slide, but it's hard to identify true predictors of who will develop hyponatremia after surgery. Certainly the small group of patients who have untreated hypopituitarism, meaning untreated thyroid hormone and cortisol deficiencies, are independently known to increase the risk of hyponatremia. Some, but not all, studies have described that larger tumors, particularly those such as craniopharyngiomas involving the stalk or compressing the optic chiasm, may be associated with a higher risk of postoperative hyponatremia. And lastly, on the bottom left panel is a study representative of a few others that have come out in the last few years. This one is from the University of Colorado, an endocrinology group, describing their protocol in which they routinely water restricted all patients for the first week after surgery, following their discharge to 1.5 liters daily, together with liberalizing their salt intake, and checked a post-op day 7 sodium level. And what they found was that prior to initiating this protocol, readmission rates for hyponatremia were above 7%. And following this protocol, the readmission rates dropped to 2.4%. So what we analyzed here, and this is the same data set that Roy showed us earlier, was data from 409 patients who underwent transphenodal surgery at our institution. And hyponatremia was indeed the most common cause of readmission. So a third of patients readmitted were readmitted due to hyponatremia. And you can see the other causes, including the cerebrospinal fluid leak percentages on the next line. Patients with hyponatremia were readmitted earlier than others. And this actually gives me pause, because the common protocols of checking serum sodium about 1 week after the date of surgery might fail. As you can see, the mean duration to readmission was only 4 days, with this particular problem. And we found this difference to be statistically significant. And among all the factors we analyzed, though there were some trends for predictors for who would be readmitted, the only one that met statistical significance was shown here on the bottom line, was that patients who had outpatient follow-up with an endocrinologist had about a 50% reduction in their odds of having readmission for hyponatremia. So I believe this is my last slide, and I'd like to ask some of our other panelists who are with us today, our neurosurgical colleagues, to share, with us what their protocols are. Do you operate and send patients home with steroids? Do you fluid restrict people or check a serum sodium at a time interval after surgery? Or what do your endocrinologists usually do?
Eduardo, would you like to comment about your experience with hyponatremia post-op after transfemoral surgery and how you guys handle it?
Yes. We worked with very well-known neuroendocrinologists that Julia Bouchan and Marcel Brownstein, Agi knows him. And we have two different philosophies. For instance, for Cushing disease, one of them want to see the patient gets worse in the postoperative period before giving the corticosteroid. And the other one, no, give the steroids, low dose steroids from the first day, and then slowly after discharge, we see what happens with the results of the ECTH. Relation to the hyponatremia, although our patients get postoperative examination of sodium twice a day and diuresis control. And if the patient is okay, he's out of the, go home without any treatment, without any observation, only serum sodium the 7th postoperative day, and to see if there is a hyponatremia. And that's it. And we see that even if the patient doesn't have diabetic insipidus in the postoperative diabetic insipidus, he must control the sodium after the 7th postoperative day.
Marvin, any comments on your practice with respect to endocrine issues?
Hi. So we send our patients home on fluid restriction at 1.5 liters a day. We actually give them salt tabs. We do not send them home on steroids routinely unless they require it for clinical reasons. And we do try to get a sodium at 7 days. So we follow that protocol.
Okay. Apio, anything to add from your perspective on that? I may have lost him for a second. Okay, Atil, shall we move on to Alex, or you want to make any other comments?
No, I'll just, emphasize what Dr. Valentini said, is that, all of what we're discussing here is for patients without Cushing's disease. Those patients we too operate without steroid coverage because of the unique ability to measure postoperative cortisol as an indicator of remission. And one other point about the study I showed from Colorado was that their protocol was only for patients who didn't develop, early post-op DI. So they didn't include them in their data set for water restriction following surgery.
Yeah.
Could I just ask, your data shows a mean of 4 days from discharge, because almost all the studies, including our data, shows 8 days post-operatively is the mean time for hyponatremia. Is your length of stay 4 days and then you have plus 4 days after discharge? Or because it's really uncommon to see hyponatremia on post-op day number 4.
Right. Yeah.
No, length of stay is 48 hours, Marvin, here in our practice.
Okay.
Sorry, go ahead, Atil.
Yeah, no, I mean, my understanding from the data is that it's post-operative, but I will review that to make sure that it's not days following discharge. Certainly that doesn't make sense.
Yeah, because there was a really interesting study out of Germany where they kept their patients in the hospital for, I forget, 2 weeks and measured all these, and it was 8 days in that study as well, where they prospectively looked at this.
And what
Very
people
low
find is, the prevalence of hyponatremia actually, or the frequency, is up to 25% of patients. So these are readmission rates, but if you start checking the sodium, you're going to find very mild asymptomatic hyponatremia in a greater number of patients.
And to your point, in terms of how worthwhile it is, we've had patients with normal sodium on day 7 and then profoundly hyponatremic on day 8. So it is also not necessarily reassuring if it's normal.
Great. Alex?
Yeah. I'm gonna share the screen here.
Thank you.
Thank you so much. Let me see here. Okay, first of all, thank you so much. I want to welcome our international and national panelists and everybody who is here, and also thank Dr. Morkos and the Cerebrovascular and Skull team for the invitation. I want to share one of our recent cases. It's a little bit of a different approach, just to make it a little bit more interesting, since Atil was going to talk about hyponatremia. This is a case we saw recently. It's a 34-year-old female with no past medical history, and she did have double vision, headaches, and no evidence of excess production of hormones, essentially. But because of this, in our right cranial nerve 6, she had an MRI that revealed basically this expanded cellular mass, or expanded cella with a cellular mass that was thick-walled. It had internal T2 signaling, and it extended into the sphenoid sinuses with abutment of the bilateral cavernous sinuses. So you can see it there laterally, and the hormonal evaluation was really unremarkable. As you can see here, the patient did not have adrenal insufficiency. It didn't sound like she had other oversecretion syndromes like acromegaly. She did have surgery. The patient was operated through a transsphenoidal approach with gross total resection of the cellular mass. She did not develop diabetes insipidus. And I know all of you know this, but this is just to remind us of what's the differential diagnosis, because more commonly pituitary adenomas and craniopharyngiomas and Rathke's cleft cysts. In our case, what seemed to be happening is that this was a moderately differentiated adenocarcinoma, and the immunohistochemistry really ruled out lung adenocarcinoma, which, as you know, it's very frequent, breast cancer, and urothelial carcinoma. So, and also hepatocellular carcinoma. So we're a little bit perplexed. We didn't know where this was coming from. A PET scan, a whole body PET scan, revealed this large hypermetabolic necrotic mass in the right hepatic lobe, and we were thinking, of course, this was the cause of her metastatic disease to the pituitary gland. And this is just to remind you that it was Ludwig Benjamin and then subsequently Harvey Cushing in 1930 who that described pituitary metastases, and they're rare. There are about 300 cases in the literature, at least until 2018 from the review we did. So it represents approximately 1% of cellular masses, and breast cancer being the most common one, lung pretty common. And visual symptoms are the most common primary manifestation. The posterior pituitary, the posterior part of the pituitary seems to be more susceptible. And frequently we see diabetes insipidus. The median survival is not that good. This just shows the same information, breast cancer, lung cancer, thyroid, and colon here. But this again is from 1957 to 2018, so you can see the cases here. These are the most common symptoms. Our patient has visual involvement and did not have any form of pituitary insufficiency, which called our attention, but we did look carefully into that. So next generation sequencing was performed in this case, and this is what I want to bring to the table, because it's been used to basically try to classify and diagnose new mutations that I think ultimately will reclassify how pituitary tumors are, or how we look at pituitary tumors. And the interpretation was that this patient had an FGF receptor 2 mutation, or it's really a gene fusion that was detected with the CC1 gene. And this mutation is rare, and it's or this gene fusion is rare and has been reported in a molecular subtype of cholangiocarcinoma. We think this is the first case reported in the literature of metastatic cholangiocarcinoma to the pituitary gland. And it sort of showcases how next generation sequencing will be used in future years. It's already being used, and this is just to show you or to remind you of how it has been used. In the old days, the Sanger sequencing studies, pragmatically for obvious reasons, looked at syndromic pituitary tumors such as McCune-Albright or NMN1, NMN4, Carney's complex, and these are the genes that we know were already described that cause pituitary tumors in a familiar form or in a syndromic form. Now, lately, next generation sequencing has given us clues of the pathophysiology of Cushing syndrome. One of the first mutations that was reported was by a group in Germany, was the USP8 mutation, the Cables1 mutation, and then BRAF in papillary craniopharyngiomas, CTNNB1 in craniopharyngiomas, the Dicer syndrome, and CDH23 mutations in familiar pituitary adenomas. So basically, I think this case shows how next generation sequencing could be used also for not only metastatic disease, but to reclassify these tumors, and perhaps they may give us some insight into the potential behavior of these tumors that can in turn guide surgery. The liver biopsy here showed a poorly differentiated adenocarcinoma consistent with cholangiocarcinoma, and the patient basically received palliative treatment with chemotherapy.
Very rare indeed. Yes, very interesting. Thank you. Nice to remind people of zebras when not everything looks like horses.
Yeah, I think also pretty much where sort of genetic testing is leading in terms to the diagnosis and classification of these tumors.
Right, right. Thank you, Alex. Marvin, let me invite you to share your slides and unmute your microphone, and
thank you, Jacques. And,
obviously, perhaps you could ask Eduardo after you show the case how he would handle it. I think Nelson may have gone back to the OR, and maybe
I'm here.
Oh, you're here.
Oh, wonderful.
I'm still listening.
Okay. And Jacques, thank you so much for inviting me to be on the panel. And I'm just curious, you mentioned zebras. I wonder if in different parts of the world they talk about horses.
You're right.
So if I could just share this case, and this is in line, I know that Nelson was speaking and Eduardo was speaking, so I wanted to find a case that maybe bridged both excellent talks. Thank you so much. It's very informative. So this pretty straightforward history, a 55-year-old female, had many features of acromegaly. Interestingly, a paternal uncle was almost 7 feet tall, and her patient was 5'8", but it does give you a hint that maybe there's something of a familial tendency there. This was her laboratory evaluation, and I just want to point to you the mildly elevated prolactin, but the pretty moderately elevated growth hormone and clear evidence of acromegaly. So again, pretty straightforward. And if we look at the tumor here, the prolactin elevation may be Salk effect, or it may be a combined secretor. But the big question here, and what Jacques asked us to present controversial cases. So what I counsel my patients is that surgical intervention for functional tumors, the primary indication is cure. Removing part of the tumor, they still end up on medical treatment or radiation, and there may be some beneficial effects with cytoreduction in terms of lower medication doses or preferred or better radiosurgical targets, but for the most part, it's surgical cure. Eduardo showed two recurrent tumors with medial wall cavernous sinus involvement. And, you know, the experience with at Oldfield with Cushing's disease really documents that recurrence is nearly always in the cavernous sinus area with Cushing's disease. And a very, very nice study out of Pittsburgh from 2 years ago, Cohen study. They took 50 patients, and every patient, they took the medial wall of the cavernous sinus and showed that in functional tumors, 83% of them had invasion of the medial wall of the cavernous sinus. So the question here is, given this MRI scan, would you counsel the patient in this case who has acromegaly, should we resect the medial wall of the cavernous sinus electively on her first operation? Eduardo, would you do it?
Good question. But in our experience, this infiltration of a cavernous sinus medial wall is more frequent in recurrent tumors. So in the first surgery, we'll see what's going on. We can see, you can remove tumor and see how is the relationship with the medial wall of the cavernous sinus. And most of the time for the first surgery, you don't see some infiltration. Maybe you can leave some residual tumor cells, but in the first time, electively, I would not propose I'm going to remove the medial wall of the cavernous sinus, because most of the time we don't need to do it in the first surgery.
Nelson, what would you counsel the patient?
Marvin, I would counsel the patient that I would not recommend doing a medial wall resection at the first go around. I think in this case, there's a very strong likelihood that the lesion may still respect the pituitary capsule, even though it's a NOPS2. The chances are that if you preserve that pituitary gland capsule, that inner layer of dura, and don't breach the gland itself, that this indentation of the medial wall by the tumor is not an invasion, it's an indentation and a compression. And if you respect that gland capsule, you can, in many cases, preserve that and remove the tumor. So I would not go for the more extended approach, unless at surgery, I saw a clear evidence that it had breached the wall, in which case, then obviously, you either have to do that or at that point, because you're not going to be able to do, you're not going to get 100% without doing that.
Yeah, no, I think those are all wise opinions. I have to say, though, that based on that Pittsburgh study, where these were cases where there was not a clear invasion on MRI or intraoperatively. These were pathological cases where they show invasion in a very high percentage of cases that are laterally aspect tumors. And also we know that the long-term recurrence rate data isn't very good. It's 20 to 30% or more cases. So here's her case. And so here's what I did. I did counsel the patient that I was going to do so. And here's just this is double speed here. I don't operate this fast. Just didn't want the video to be that long. So found that pseudocapsule. Pseudocapsule's nice, so you can literally grab it and pull on it and find that plane, and you just keep coming around to maintain the normal pituitary gland. And I used sharp dissection. Superiorly, this tumor came very high, and there was a small CSF leak that was encountered, and kept coming around, and actually had a very nice plane here. You can see the medial wall, the cavernous sinus there. It looked clean, and removed the tumor, but you can see the medial wall there. This dura looked a little ratty superiorly, so I resected that as well. But here I'm using ultrasound to confirm where the carotid artery is not. and opening up the inferiorly first, and just starting to do this dissection here to enter the cavernous sinus inferiorly, and there's a little nubbin of tumor down there. You can see there the cavernous sinus. There's the carotid artery, and there's the medial wall of the cavernous sinus, which is now just resected sharply. Remove that anterior dura as well to remove that tumor. I couldn't quite get enough access, so I had to drill more bone inferiorly to get at that inferior portion. You can see there the venous bleeding from the cavernous sinus, and finally the resection of the mass. So this is a case here where the radiology and even the intraoperative findings were not very suggestive of cavernous sinus invasion, but I chose to do this. Again, I counsel all my patients that I take the Oyusiku view that the first case is the best time to get a cure. And here's a flap, and here's the balloon that we use to hold that nasal septal flap for cases that are superiorly, where we really cannot get a good purchase. You can see the interface here of tumor in that cavernous sinus. It's staying positive for growth hormone, and she actually was not adherent to fluid restriction. It came back with hyponatremia, but she's doing well, and her postoperative growth hormone was 0.7 at 8 months, 0.1, and her with normal IGF-1 values. So just thought you might be interested how we do it. We do take a pretty aggressive stance and routinely resect medial wall cavernous sinus and Cushing's, Prolactinomas, and Acromegaly, if the tumor goes laterally.
Nice case, Mark. Comment?
May I ask you, Jack, the problem is we don't have such a clinical parallel between those pathological examinations and the clinical course of the patients. So sometimes you can see invasion in the microscope in the laboratory, but the follow and the clinical course of the patient is different. And otherwise, if the tumor is just is not invaded the medial wall, is just on the medial wall, and you see there is no infiltration, and you say that you must remove, because the tumor is very closed, you must remove all the dura, the anterior dura, the inferior dura that has some contact with the tumor also. You see, that would be a radical removal of all the dura that is in contact. Medial wall, anterior dura, and inferior dura that is in contact with the tumor also, in order to avoid the recurrence.
We do remove the inferior dura as well.
Yeah. So it must be not only the lateral wall, the medial wall, but only all the dura.
I think the presumption is that the medial wall of the cavernous sinus is because there is a hidden chamber behind it, unlike the other. I see your points, Eduardo, but I mean, that's the presumption, is there is potential space behind it where, as he showed in his video, he would have missed a small piece, correct, Marvin, on the other side. Yeah.
Yes. Yes.
Yeah.
I have a question for Dr. Berg-Snyder. That's okay. So when you're faced with cases like this with acromegaly with an invasive somatotrope adenoma, especially into the cavernous sinus, do you consider pre-treatment with somatostatin analogs to shrink the tumor to make it more easily resectable or curable?
So it's a great question. So again, I didn't think preoperatively that this patient had an invasive tumor. I completely agree with the other surgeons here that it looked like it was just impinging or pushing on the wall, and didn't expect necessarily to find this. So I have a pretty simple approach. If they're clearly invasive, they actually go to medical treatment, because in my long-term response rate to gross cavernous sinus invasion is very low durability on remission. So we actually give them a trial actually for permanent treatment, not just, I haven't found much utilization or utility of, I guess, utility of shrinking it down before surgery. If the horse has already left the barn and is, medication is not going to bring that horse back into the cell. Or zebra, I'm sorry. I forgot which part of the world I'm in. Yes.
It's okay, we're international. We take
Okay.
all comers. Great case. Appio, can I get you to share your slide and unmute your microphone? And after Appio presents his case, perhaps I can ask Carolina Benjamin, my partner, to comment and perhaps field some of the questions from the audience.
Well, is that okay?
Yeah, but put it in presentation mode, yeah.
Okay, well, Jack, thank you for the invitation. And well, I live in the south of Brazil. This is my university hospital, which are, as I just recently noticed that our colleague has been here some years ago, the Endocrine, your friend of mine. So Porto Alegre, as you know, in the south of the country. I'm very proud to be here because, as you can see in these pictures, in the pituitary meetings and skull-based meetings, we met together with Nelson and Jax. This case I'm going to show you is a very common case of big tumor, but there are 2 points for the discussion that I want to tell you according to hear what would you do. This is a 59-year-old male of 9 years history of headaches and progressive loss of vision. This patient was hypertensive, obese, had bilateral glaucoma and diabetes. The endocrine people has seen him and said that he had hypogonadic and central hypothyroidism. He was put on prednisone and cabergoline, as you see. We sent the patient at the outpatient clinic. The patient was blind of the left eye with severe loss of vision of the right eye. And this was the visual field on the good eye, if you can say good eye. And this was the case. I would like to hear from the panel, what would they do with this case, considering 2 points. First, just to advance the discussion. This was a hard, very hard tumor, and the patient had only one eye, and he said definitely, I won't accept any at all empeoration of my vision of the right eye. So we had 2 problems, hard tumor and only one eye working, and the patient wouldn't accept any change at all. So please, all the neurosurgeons and endocrine people, what do you do with this case? And I show you what I have done later.
Before the answer, Appio, what do you mean hard tumor? You mean based on MRI, you thought?
No, based it on my operation.
Oh, I see.
I can tell you.
Right,
Just
right.
because if it was it was a hard tumor, it was an easy task for you to take this tumor out.
I understand.
And this was a non-secreting hard tumor, and the patient wouldn't accept any change in his only eye vision.
Maybe perhaps before the neurosurgeons on the panel answer, maybe I can open it up first to our endocrinologist and take this opportunity to ask them, is there any appropriate medical treatment for non-functioning pituitary adenomas, Atil and Alex?
I'll defer to Alex.
Okay.
Not really. My answer is not really. I think that there are a few. I mean, there are a few things that can perhaps, like even the somatostatin analogs, could decrease the size, of 20%, of non-functioning adenomas. But for this type of tumor, I don't think it's.
I just wanted the audience to the young people in the audience to hear that clearly.
Atil,
Okay.
I don't know if you opine differently.
Yeah, I think there's some retrospective reviews showing about a 10%, response rate with somatostatin analogs, and some studies from Israel I've seen using dopamine agonists, but they're not, you need a dramatic response, so if this is a prolactinoma, yes, we see dramatic responses with cabergoline, but for non-functioning tumors. Another thought is that, for pituitary carcinomas and aggressive tumors, sometimes temozolomide has been used by our neuro-oncology colleagues with great success. And so we usually don't prescribe that as the endocrinologist, but it could be considered.
Maybe, shall we ask Eduardo, since he was the invasive pituitary lecturer today, how he would handle this?
Yes. For very giant, large pituitary adenomas, of course, you could do a transnasal approach if you if the tumor is soft, or at least you have some indication through the MRI with T2 MR if the tumor is soft. Because the problem with those large tumors is you go from a transnasal approach, the tumor is hard, you remove part of the tumor, and there is a high risk of bleeding in the postoperative period. And as in these patients, the main purpose of the surgery is optic nerve, optic chiasm, decompress optic chiasm, optic nerve. And if the tumor is hard, or in T2 seems to be a hard tumor, I'd go a transcranial approach from the left side, where the tumor is on the left side, the worst vision on the left side, and decompress the optic pathway. This would be my for these patients, what I do.
Nelson, are you with us?
Yeah, hi, Jack.
Hey. Is this a good transsphenoidal case in Emory, or it's a transcranial case?
No, it's not a good, it's got some strikes against it for the transsphenoidal. It's a shallow cellar, so that's one. Number two, it's multi-compartmental. It's breached it looks like it's breached the arachnoid, at least in one area, if not two. And there's some uncertainty as to, I can't tell, maybe it will show in some other slices, whether there's any encasement at all of any of the anterior circle, maybe the...
I think you can see it at the top left, correct, Apio? That's the ACA, well, 180-degree encasement, isn't it, Apio?
Yes, that's right.
Yeah.
Yes.
Yeah, so it seems to me that there's at least the very likely possibility, just looking at these, that there will be some encasement of that A1 or maybe part of the ACOM complex. But long story short, those all make it more hazardous. And if I heard Apio right, he said the tumor was hard, and I don't know whether he meant it was firm or fibrotic. It has these very dense fibrous appearance to it as well, that also suggests it might be a little bit densely packed, firm, fibrotic kind of a tumor. So I think that a safer option would be what Eduardo also proposed, would be a craniotomy, or at least a staged operation, and maybe starting out with one or other approach. Generally speaking, when we're going to do staged approaches, we do our transsphenoidal first, so we don't get, have the problem of a craniotomy and an opening into the arachnoid and a leak to start with. But I think a craniotomy would probably be the safer if I had to pick just one approach.
Nelson, if I can pick on this point, I've had experience, and I heard Bill Caldwell talk about it, partial resection transsphenoidally, leaving a significant portion, and kind of, when you say staging, I don't know what period of time in between, but I'm sure, the hemorrhagic transformation of the residual is a serious issue, isn't it?
Right. So you wouldn't, again, as I said, you wouldn't be going for a long interval, like weeks or something. You want to do it as soon as possible. The other way we've done things in the past in that regard for giant adenomas that are multi-compartmental is to do a combined simultaneous. And so you do a combined simultaneous operation, craniotomy and transphenoidal. And that way you eliminate any problem about, worry about a hemorrhagic setting in the day of or the day after.
Marvin, how would you handle this?
So I think it's unfair for us to know that it's firm because
I know I was, yeah, I wish I could say it so he could give you, well, let's say you don't know. You don't know.
Exactly. So I was going to answer the question as if this presented in my clinic, and I'm not sure there's any one approach that can remove all the tumors safely because you're blind to some part of the tumor through, I think, any approach that you use, unless the tumor is soft and just happens to fall out. So, I mean, when I look at a tumor like this that has extracapsular, extradiaphragmatic extension, I kind of approach it more like a tuberculum, a meningioma, and which are firm. And so you do a transplanum, transtubercular, transcellular exposure, and rather than trying to deliver the tumor by softness and suction, that you literally find the arachnoid plane, find your optic nerves, decompress your optic nerves and chiasm, and whatever you can't deliver safely because it's blind, then you can come back via one or more craniotomy approaches. So that's what I would have approached this via that approach.
Okay, should I go on, Jack?
No, hold on. Let me ask my partner, Carolina. Carolina is 1 year into her practice with us, and she did a fantastic fellowship with Chandra Sen and Doug Gonziolka, and I'm curious how she would handle it. And if I don't know if Mike Ivan is still on the panel, I'd like his opinion too. Go ahead, Carolina. You're muted.
Hi there. So, it's interesting. Again, obviously the consistency would be important here. One thing that does concern me a bit is also the edema that we see there on the brain itself, that, maybe the dissection planes are going to be a little bit more difficult from an endoscopic standpoint. I'm sure they would tackle this, in Ohio State or Pittsburgh endoscopically and probably do a fine job drilling. I totally agree. They would drill out planum and tuberculum sella and everything. And I think for me, just starting out, this is probably safer in my hands to do transcranial.
Would you come from the blind side or the good side, Carolina?
He's very keen on his on keeping his good side, but I think with the lateral extension that we see there on the left side, I think I would probably be coming from that left side. Make sure you get it all there. But I would be concerned, if you go at this endoscopically and you do leave tumor behind, that you're just going to make him worse and possibly compromise the vision on the other side if that's what it, if that's where the pressure is when you have a post-operative hemorrhage.
All right, Apio.
Okay, so, well, of course, I told you it was a hard tumor, but I didn't know beforehand. So, in fact, I decided to go transnasally endoscopically. And we couldn't get much tumor. We did, but it was very hard, even though using ultrasonic aspirator we had. So what we could take of this tumor, you can see, especially in the sagittal one, we could get quite a good bit of tumor, but that big piece up there into the third ventricle and the lateral, we couldn't. This confirmed it to be a non-secreting tumor. And he's got post-operative diabetes insipidus. He was put on DDAVP. He said there was a mild recovery of the right eye vision, but nothing very important. Okay, so what happened then is that, well, of course, we asked the people from radiation oncology. They said, no, there's no way for irradiation. And the patient said, well, I don't want any other operation. I don't want to be in risky of losing my good eye. So the endocrine people decide to put him on temozolomide, as was told before by, which one of you told about it? I'm not sure.
Yeah, no, Atil, one of our neuro-oncologists.
Yeah, that's Atil.
Yeah.
And okay, so the patient said, I don't want to be operated anymore. He was put on temozolomide. Temozolomide didn't work at all. 6 months later, the tumor was a little bit bigger, but not enough, to change his visual fields. But he had a fit on February, and he was put on a carbamazepine. And we said again, you should be operated on. So we decided to go transcallosal to get the tumor, that big part. As you can see, tumor was big again. This was post-operative. We went transcallosally, and that was we could take transcallosally. The upper part we could take, the inferior part we couldn't, especially because the patient stated, I don't accept any risk of my vision. Okay, he said there was a partial improvement. He was feeling okay. And this was the post-operative MRI. So we could take the big part, but still there was tumor growing up to the left side where he was blind. So what would you do now? Would you go Transylvian? Would you stop? Would you send for radiotherapy?
Anybody on the panel, or you can offer your opinion.
Can I, Dr. Antunes, Alex Ayala here, a quick question. I think this is, am I incorrect, but this is a silent corticotropinoma, correct? Because it stains for ACTH strongly, I believe, from what you showed. So this would be classified as about
secreting.
It was, and because it's stained for ACTH, it would be classified as a silent corticotropinoma. About 20% of corticotropin-producing tumors will be stained, and they correct the main. And there is, as you well know, there is evidence that they may be harder to remove. Do you know if it had Crook cell changes?
No, I don't. There were no Crook cells.
Because I recall a paper where a particular paper where they report the results of gamma knife radiosurgery in patients with Crook cell adenomas and silent corticotropinomas. I'll try to find and send to you if I find it. But
but the question was, the people said it's too big for irradiation.
No, for sure. I was just wondering if they tend to. I think this paper in particular look at the response to radiation in particular. But I think that it would qualify as a silent corticotropic adenoma.
Yeah. Okay. Enio?
Apio, I tell you what I would do. I would not have done the transcallosal. I would have done left cranioorbital extradural clinoidectomy to enter the sella from, and of course, intra and extradural resection coming in from the blind side, cutting the left optic nerve, the blind nerve, if necessary, and going, doing maximally what I can do, and that's it. That's, I think, what my approach would be.
Okay. Should I go on?
If nobody else, yeah, sure, go on.
Okay, so tumor was still there. The big part up was gone. So we said the patient, you have to go again for a new operation because the tumor is growing up. And he said, I accept, but I don't accept any change in my vision of right eye. So we decided to go Transylvia-Terional approach. We did, as you said, we sectioned the left optic nerve. We've taken the most we could, but there was still tumor remaining. So we decided to irradiate him. He was irradiated. And I didn't get the films, recent films after radiation, but there is still tumor there. And the patient still have the same vision on the right eye. So the question is there anything else to be done for this patient for this remaining tumor?
He was radiated 2 years ago, I see from the date.
That's right.
My opinion is, I mean, it's too early to no. I think you sit tight and wait. I'm not sure if my colleagues have a different opinion.
Yeah, I don't see a reason to do anything else at this minute.
Okay, but so
you're going to be forced to do. He may not respond to radiation, though, so you may want to save your next surgery for the next the next chapter in this saga.
But what approach?
It looks like the tumor dropped, and you can actually go transpheroidal again.
Yeah, because most of the tumor is inside the cell now.
If the tumor grows, then the only option you have is surgery. You don't have any other option now. If the tumor grows, and if the tumor grows, with this tumor, what we see here, the best option is transcellular again. But if the tumor doesn't grow, doesn't do anything, just wait a little bit.
The difficulty obviously is if it was already firm. I'm imagining that the radiation's not going to help in that scenario.
Yeah. And
is there a specific Brazilian juice you can put on this that loosens it?
Yeah, maybe orange juice.
At this stage, pastereotide, if you're asking about medical therapy, could be tried, since there's a wealth of data about using it in Cushing's disease, and this is a silent corticotrope adenoma, that it does affect tumor shrinkage. Earlier it was a huge tumor, but at this point, something to at least prevent it from growing further, it could be attempted. It might worsen diabetes. It's its most common side effect.
Well, tell Fernando.
I'll tell Fernando's a
endocrinologist
in Porto Alegre. He's also met Alex.
Yeah. I know Fernando. I know it may shrink a little bit, the tumor, but it's fairly comparable to a creotide, and it would be a modest decrease at the expense of almost a big percent develop diabetes with the drug. So I'm not sure if it's going to do much with it.
Yes, and my feeling, I showed this case because besides the fact that it was a hard and very big tumor, the patient said, definitely, I don't accept any change in my vision. So one had to be very careful in all these operations, not to damage the right eye. That was my worries, because perhaps I could have taken much more tumor in one of these operations, but the question that he wouldn't accept. So I was very, very careful, perhaps more than I should do, but I've been very careful.
The first time around when you did the surgery, did you do any bony optic canal decompression from the endoscopic?
No, I didn't. No.
The approach.
I want to congratulate you that you didn't blind them on 3 different operations. So that's an achievement in itself, because these giant pituitary adenomas have a very high surgical complication rate. I think there was a mention of apoplexy, which is not unique to transpheroidal approach. I mean, every approach that you performed had that same risk of apoplexy, and it usually occurs in the softer tumors, by the way. I think that's my experience, but I think that you're going to have, from 3 different approaches, so much scar tissue in there now that a 4th operation will run that high risk of blindness. And you given radiation just 2 years ago, I would not touch this with a 10-foot endoscope.
Or I can invite any of you to operate on him. Well, okay.
Hopefully it won't be needed. Thank you, Abdo. It's a great case.
Please come to the sunset in Porto Alegre, please.
We will, with a picture like this. Who can resist? Thank you. Well,
Thank you.
We'll finish up with another Brazilian, Carolina. Maybe we can spend a maximum of 10 minutes fielding, and if necessary, up to 10 minutes. Any questions you've come across in the Q&A from the audience?
Okay, so a few good questions here about all the excellent talks. How helpful do you guys think dynamic MRIs are in identifying functioning microadenomas that were not detected on a conventional MRI with pituitary protocol?
I think they're very helpful.
Yeah. Okay.
They do them all the time.
We haven't found them as helpful as we would have liked. The number of cases that with high resolution 3T scanning that we found one on dynamic imaging is very low, and they're very equivocal often. They're hard to interpret, at least for our radiologists.
We like them quite a bit here at UM also, Marvin. You know, our endocrinologists can attest to cases that are better. They're not 100%, but better seen compared to a static MRI. I don't know. I won't speak for them, but
we do them. I'm just saying, in my experience, they've been helpful in a minority of cases.
We use a lot of dynamic because I think for small tumors, it's very helpful.
Yeah.
And I think for small tumors, microadenoma is very helpful.
Maybe Till can comment also, but I recall at least 2 or 3 cases within the past 2 or 3 years that were not, the tumor was not seen on conventional MRI that we
turn over to OR 25, case to follow. Turn over to OR 25, case to follow.
That's not me. I wouldn't operate on you.
Oh, Carolina, next question.
All right. Dr. Isiko, what is your criteria to take a patient back for an early second exploration? Do you repeat immediate post-op MRI and consider re-exploration for every patient that doesn't reach a cortisol nadir less than 2 in the post-op period?
No, we don't do post-op MRIs on Cushing's because, as I mentioned in the talk, it's really not an anatomic problem. It's more of a biochemical problem. And the criteria would be if we found an adenoma on the first exploration, that would be strong evidence to go back. So there was an adenoma found, and we always do IHCs on all our cases, so we'd know if it was an ACTH positive adenoma. So that would be even more evidence to strengthen our hand to go back. If the patient had an IPSS that strongly localized to one other side, we would feel much more comfortable in going back to extend the margin of the resection, either laterally or medially, depending on which area was most suspect. And again, if there was a good initial response biochemically that you know, we didn't quite get all the way down to 2, maybe we petered out about 9 or 8 or something, and maybe it started out at 40 or 30 something, but it had plummeted quite a bit. And so we'd be very encouraged that we're right there in the ballpark to get this patient off and running. So those would be some of the thoughts that would go into the discussion of going back in on an early re-exploration.
Okay. What is your, actually on that note, Dr. Isiko, do you guys have intraoperative MRI?
No, we do not.
And do you feel that that's does anyone on the panel use intraoperative MRI?
Maybe Eduardo,
but it doesn't help for at least for cellular adenomas, maybe for invasive or very lateral. For cellular adenomas doesn't give some help now.
We used to have an intraoperative MRI scan, and basically if you can't reach it is the problem with endoscopy. I found it's not that you didn't see it, it's that you just can't reach it.
And Carolina, you know, on the point about the post-op cortisols, it isn't that infrequent that we see some delayed remissions. You know, I can think of a handful of patients that we've had in the last few years. So I would venture to say, you know, if the surgeon feels that they did a pretty good resection and, you know, the cortisol is above 2, it's reasonable to discharge the patient and have outpatient follow-up, and you'll find, you know, a group of those will actually go into remission.
I think we have the same experience. And I just want to, if you believe in episodic Cushing's, some of those patients don't fall as quickly as other patients because I think there are times where they actually have normal corticotrophic function from their pituitary gland. At least that's my presumption. So I think what Nelson, what you describe is the classic patient that's always on Cushing's that falls very rapidly. But it's these other patients that fall slowly. And sometimes we don't want to wait after 3 days that they're still falling.
Yeah, there's a paper out. There's a paper that was written about that some years back from Brooke and the group at MGH, and it is in fact the case that there are the delayed responders, but they're a very small cohort. They're not, they're not 60% or 70%. They're a small percentage of those patients. So if the patient is not fully suppressed in terms of their normal gland, yes, they might not fall all the way down. Whereas if their normal gland was fully suppressed, then they have a more likelihood of falling the way down. So it's not one decision point. I think it's a constellation of factors all adding up that would all point in the direction that, you're there, but maybe not quite there. And that would be how we would weigh the evidence.
And just to complement that, there is some evidence, and that's probably because maybe some of these patients are not completely cured to start with, but that those late responders may have a higher incidence of recurrence in the future.
Right. I think that was the case at least certainly the big series, ED series, and those kinds of numbers. That when you don't get that, it's when it's in the 2 to 5 range, where it's sort of a little bit, not quite there, but better. Those are the ones that tend to sort of recur down the line more likely than not.
Okay. A couple more questions. Do you guys have any tips or tricks on how to find the pituitary stalk in a firm tumor, like the one you just showed, Dr. Antunes?
Well, that's a good job and a good question. Because if the tumor is very hard, sometimes we don't see the stalk. In this case, for example, I haven't seen the stalk. I was not sure, but fortunately, in this case, he was hypopit before. So I was not much worried, but sometimes it's very difficult in my hands. I don't know about the panel.
Anyone else?
Yeah, for a supracellular tumor, as I said, if you treat it like a meningioma and separate the arachnoid and go supracellular, you can drop these tumors. This one was not going to drop because it was up into the third ventricle, but you can find the stalk, just like a craniopharyngioma or meningioma, through a transarachnoid approach.
And one last one, I guess this is coming from Lima, Peru, and they're asking, in these times, has everyone sort of returned back to doing their usual endoscopic transsphenoidal surgeries, or are there any restrictions that you guys are using, or have you just been proceeding with precautions at this point?
We didn't have any restriction anymore. We do the PCR examination 2 days before, and with all the protective masks. And the first pituitary surgery since March was in July, 3 or 4 months after. And then after July, we get free and we operate everybody.
Yeah.
With protective masks. Okay?
It's very
and
courageous.
PCR before.
Well, I have one question to the panel. I know we are about to the end. Is there any one of the surgeons have experience with fluorescing for better in between inverted commas to diagnose intraoperatively the tumor?
I haven't, but our colleague John Lee in UPenn and several others have talked about it, and Paul Gardner in Pittsburgh. I don't know if anybody else on the panel. Nelson, have you played around with intra-op fluorescence to sharpen your detective skills in finding a microadenoma?
No, I haven't, but I've seen John's work, and actually, you may know this. The work that he did up there was a translation of our work in looking at our tumors that we found the folate receptor overexpression in pituitary clinically non-functioning adenomas, and the ligand they used was against that folate receptor imaging. So
I did not know that. Okay.
yeah, but yes, I've seen those images, but I personally haven't accumulated any experience in that.
Because we have a colleague very close to you, Jax, in Mexico City, Juan Amador, and he has a very nice experience using, and he uses both the microscope and the endoscope at the same operation. And he says that to him, it helps a lot to identify properly the tumor.
Okay, Carolina, I think that's kind of most of the questions.
Yep.
I cannot tell you how much fun this was, having all these brains around this panel, and the audience has had a treat listening to this multidisciplinary panel. Sorry it went a little long, but that's only because it was very fruitful. So thank you to all in all parts of the world. My good friends, thank you. Hopefully let's meet again in person.
Okay.
Thank you. Bye.
Okay, bye-bye.
Bye.
Ciao, ciao.
Ciao.
So